pretty worrisome. Indeed, hypnotic medications have many limitations, especially when they are used on a daily basis for several weeks or months. They can lead to many residual effects the next day, such as daytime sleepiness, dizziness, also a reduction of motor and cognitive functioning. Tolerance can also develop, which implies that patients will need to increase the dosage that they're using to obtain the same effect. Dependence is also likely, especially psychological, as well as some modifications of sleep architecture. So that's what made the NIH recommend in 2005 to use hypnotic medications mostly for acute and transient insomnia at the lowest dosage possible, and for a short-term utilization lower than 4 weeks, ideally. And that's why cognitive behavioral therapy is now considered the treatment of choice for primary chronic insomnia. It has been found to be efficacious in patients with insomnia comorbid with chronic pain, fibromyalgia, a medical or psychiatric condition, and also in older adults with mixed medical disorders. In the specific context of cancer, there is an increasing number of randomized controlled trials that have been published, and overall the results have been quite consistent in showing that CBT improves sleep, decreases psychological distress, and increases quality of life. Also interesting to note that recent randomized controlled trials showed that CBT was more efficacious than mindfulness-based stress reduction intervention. CBT for insomnia address behavioral and cognitive factors that are believed to be instrumental in maintaining the sleep difficulties over time. Behaviors such as spending too much time in bed, having an irregular sleep-wake schedule, and watching TV in bed all contribute to desynchronizing the biological clock and weaken the association between the bedroom or bed with sleep. With regards with faulty beliefs about sleep, they maintain the sleep difficulties over time, mainly by creating what is called performance anxiety. The more the person thinks, tonight I really have to sleep because of this or that, the less likely they are that they will fall asleep rapidly at bedtime when awake or when awake during the night. CBT for insomnia is a multi-component intervention which usually comprises the following components. So you can see here stimulus control, which is a set of instructions to modify the maladaptive sleep behaviors that insomniacs tend to have, such as spending too much time in their bed and having irregular sleep schedules. So an example of that is that we instruct patients to, when they're unable to fall asleep or go back to sleep during the night, to leave the bedroom and return only when they feel sleepy again. A second component, which is usually comprised in CBT for insomnia, is sleep restriction. And this is a technique where the goal is to curtail the time in bed to the actual sleep time based, for example, on a sleep diary that the patient completed before. The third component is the cognitive restructuring in order to revise the maladaptive cognitions about sleep, such as, if I don't sleep well, my cancer will come back. And a component that is almost always included is sleep hygiene. Although it's not the most effective, it is usually used. And the goal is to change some behaviors and environmental factors that may have a negative impact on sleep, such as utilization of caffeine, exercising, exposure to light, etc. And also, relaxation is sometimes included in the treatment protocol, although not always, so it does not appear to be an essential component of the intervention. So although the efficacy of CBT for insomnia comorbid with cancer is well established, the accessibility to this treatment is very limited in routine care. There are many reasons for that. One of them is that there's not many healthcare professionals that have been formally trained to administer CBT for insomnia. And also the cost associated with the treatment sessions that usually comprise the treatment is another barrier. So we felt that there was a need to develop other intervention formats to increase dissemination of CBT for insomnia in cancer patients. So we developed a self-administered intervention composed of a 60-minute animated video and 6 short booklets that is administered over a 6-week duration. Here you can see the characters of the video as well as the content of each of the treatment weeks. So during week 1, we cover the basic sleep facts. On week 2, we explain the stimulus control and sleep restriction strategies and so on. Then we conducted the pilot study in breast cancer patients to assess the feasibility of that intervention and to provide some preliminary data on its efficacy. And we found that that was conducted in 11 breast cancer patients. And we found that patients were highly satisfied with the treatment content and their sleep improvements at post-treatment. And also, the preliminary results indicated clinically significant sleep improvements at post-treatment that were sustained at a 3-month follow-up. So given these very encouraging results, we were ready to move on to a larger randomized control trial. So we designed a study to compare the efficacy of our video-based CBTI to a professionally administered CBTI and also to a no treatment condition on various subjective and objective measures of sleep and variables also often associated with insomnia. For that study, we recruited participants who completed radiation therapy for non-metastatic breast cancer in the past 18 months. And also they had to obtain a score, an ISI score, which is the Insomnia Severity Index, of 8 or greater, or reporting using a hypnotic medication 2 nights per week or 2 nights in the past 2 weeks or more. We recruited participants directly at the clinic, and patients who were eligible at screening were invited to a clinical interview in order to assess in more detail their eligibility. And those patients who had no insomnia symptoms when we met them at the clinic, but who were otherwise eligible, were invited to participate to a phone screening procedure that was repeated every 2 months. This is a busy slide, but I only want to emphasize that we recruited 182 patients directly at the clinic and 78 patients from the phone screening procedure for a total of 260 participants. And we excluded at the clinical interview 18 patients, so we randomized a total of 242 patients. patients were randomized either to one of the three following conditions. So 81 patients were assigned to the PCBTI, so the professionally administered intervention, which was composed of 6 weekly sessions of approximately 50 minutes. 80 patients were assigned to the video-based intervention, and that was composed of the same components I explained earlier. And we assigned 81 participants to the control group, so the no CBT group. We had 5 time points in the study, but today I'm going to present only the pre- and post-treatment data. Those are the main participants' characteristics, and I only want to point out that we found no between group differences between the 3 conditions at baseline on any of these variables. We assessed a variety of variables for that study. The main outcome measures were the subjective sleep measures, which included the Insomnia Severity Index, which is a 7-item self-report scale assessing insomnia severity. We also used the sleep parameters that were derived from a daily sleep diary that was completed for a period of 2 weeks at each time assessment. We also had actigraphic data, but that was only for a third of the patients who were randomly selected at the beginning of the study, and patients who were selected were the actigraph for a period of 1 week. And we also assessed anxiety, depression, fatigue, quality of life, as well as dysfunctional beliefs about sleep. I'm not going to go into too many details here. We used intent-to-treat analysis and mixed models. We investigated several variables as possible covariates, but none of them was retained in the analysis. Now, the results. As you can see here, we found that the video-based intervention was associated with a significantly greater reduction of ISI scores at the post-treatment assessment as compared to the control condition. So the yellow line is for the DCBTI and the gray line for the control condition. But we also found a significant difference between the two intervention formats. So, and you can also see that the effect sizes, the D values that you can see here, that there was a difference between the control condition and the video-based intervention, and we also found that the professionally administered intervention had a larger effect size than the video-based intervention. We also found significant group by time interactions for many of the sleep parameters derived from the sleep diary. Here I show you 2 variables, total wake time and sleep efficiency. And again, you see a significant difference between the video-based intervention and the control condition for both variables. But you see that the difference between the 2 intervention formats was not statistically significant, although there was a trend for total wake time. But again, you see that effect sizes were consistently larger in the PCBTI than the VCBTI, which were larger than what was found in the control condition. This is a busy slide. This is only to summarize results obtained on the other main variables. So except for 2 additional parameters derived from the sleep diary, we found that the PCBTI was associated with significantly greater improvements than the VCBTI. And we found no significant group by time interaction on quality of life and any of the actigraphic data. And again, the effect sizes were consistently larger in PCBTI as compared to the BCBTI, which were larger than what was found in the control condition. This is the remission rates by treatment condition. And you can see that we found the remission was defined as having a score, an ISI score lower than 8. And you can see that in the BCBTI, we found a remission rate of 71%. And that was significantly greater than what was found in the BCBTI, which was 44%, which was significantly larger than what was found in the control condition, which was 26%. And here you can see we looked at the moderating role of ISI severity at baseline. So basically what we did was to separate patients into low ISI score and high ISI score at baseline. And again, you can see that BCBTI was consistently associated with lower remission rates in both subgroups, but that the difference was particularly pronounced in patients who had a high ISI score at baseline. Only 21% of patients, of BCBTI patients, went into remission at post-treatment as compared to 50% in the PCBTI. Sorry about that. So in conclusion, BCBTI was associated with greater sleep improvements than the control condition on most sleep variables. However, the professionally administered intervention was more efficacious than the video-based intervention on several variables, including some of the sleep parameters and also almost all other variables that we measured, such as fatigue, anxiety, and depression. So our video-based CBTI appears to be a valuable alternative, but face-to-face sessions remain the optimal format for administering efficaciously CBTI, especially in patients with more severe insomnia at baseline. We still have a lot of work to do, so our future analysis will investigate the sustainment of treatment effects over time. So we will see if those differences remain over time until 1 year after the end of treatment. We will assess the differential impact of PCBTI and BCBTI on sleep-wake patterns as assessed with actigraphy. We will compare the cost-effectiveness of both interventions, so we add also cost measures that I didn't present today. We will evaluate cost savings associated with insomnia treatment as compared to the control condition, and we will assess the role of treatment adherence on efficacy. So the take-home message is that insomnia is very common in cancer patients. It is associated with numerous negative consequences. CBT for insomnia is the treatment of choice, but is not widely accessible, unfortunately. A self-administered form of CBT for insomnia appears to be a valuable alternative, but should probably be better viewed as an initial treatment of a step care model. And I'm going to take a few minutes to explain a little bit what is a step care model. Recently, Colin Espie proposed this step care model for the treatment of insomnia. With this model of treatment delivery, each patient receives the level of intervention he or she needs. Typically, the entry level is a minimal intervention, such as the video-based intervention we developed, but it could also be bibliotherapy or an internet-based intervention. And then patients who go into remission following such minimal treatment receive no additional treatment, while others step up to a more intense form of treatment. So here you can see that it could be CBT administered in small groups, delivered by a trained therapist, and then the next step could be an individual or small group of CBT delivered by a graduate psychologist, and then individual tailored CBT delivered by a clinical psychologist, and then an expert CBT delivered by a behavioral sleep medicine specialist. So this scheme model has several steps, but it could also be more simple than that. For example, we are presently launching a large RCT of 300 cancer patients in which we will assess whether a step care model beginning by an internet-based intervention followed by individual CBTI administered by a professional is as efficacious as standard CBT administered face-to-face. So stay tuned because we will have much more interesting findings to present in the near future. Thank you very much for your attention.
Thank you, Dr. Savard. Very interesting talk. And I know the next time I can't sleep, I'll try to implement some of your sleep hygiene interventions to help me get back to bed. Now, we'd like to open it up for any questions or to start any discussions. We've opened up all the mics, so if anyone wants to jump in.
This is Richard Wassersug in Vancouver.
Hello?
Can you hear me? Richard
Yeah,
Wassersug?
I can.
I'm Richard Wassersug. I'm a prostate cancer researcher at in Vancouver. Can you hear me?
Yes, I can hear you.
Can you hear me, yes?
Yes.
Okay, so I have two questions. But first I want to say, Josée, you do fantastic research and you give great talks.
Thank you.
You're welcome. So my first question concerns your early part of the talk, where you pointed out that the insomnia problem is worse for breast cancer and